which will be by Dr. Sridevi Warrior, who is a palliative care physician. She did her certificate course in palliative medicine from Pallium India, and she did her diploma palliative care from fellowship in palliative medicine from Institute of Palliative Medicine, Calicut. And also she did her MSc palliative care from Cardiff University, UK. She has more than 10 years of experience in palliative care. Now she is working as a head of education department. Welcome and over to you, ma'am.
Thank you, Shiva. Thank you all the participants for joining us today. I hope some of you will be switching on your videos in between whenever we are having discussion. It will be nice to see and talk than talking to black square. So I will be calling out names if no one is responding. I'm so sorry for that. Today we will discuss about respiratory symptoms in palliative care. So we know that every day when new nurses go and take the vitals, one of the vital signs that we record or we give importance is respiration, right? Along with pulse, BP, temperature, one thing you all document is respiration. And we don't really give more attention to respiration. We just check the respiratory rate and come on. But respiration is more than, I'm so sorry, more than just a physiological process. There is much more to respiration than just the physiology of taking in the air and breathing it out. Many people talk through respiration. They convey a lot of things when they are breathing. If you have noticed, when we are anxious, it's very different. When we are calm, it's very different. Or when you are depressed, it's very different. Breath is, especially when it comes to palliative care, you need to read the language behind each breath than just checking this, whether it is abdominal or need to understand the language hidden. I'll just discuss a few scenarios where we get representative of a few patients. So this was very relatively young female. She was 50 years old. She had a husband and very grown children, two girls. And she suddenly started developing shortness of breath for 2 weeks. So what we will all do, we'll go to a nearby hospital and get it checked. They took the X-ray and everything. They didn't take the X-ray. They started her on some bronchodilators and some medications. She was not asthmatic. She was not hypertensive. And then they took the X-ray because it was not resolving at all, even after medication. And then they saw multiple radiopaque lesions everywhere in the lungs. So then it came to a fact that it was a metastasis from an unknown primary. So she had cancer somewhere and the whole lungs were mets. And that was the reason for her breathlessness. And she was admitted to respiratory ICU and she was on continuous oxygen. And she was referred to palliative care. Either you can go home because there is no treatment because it's unknown primary. She had to go through extensive investigations to understand the primary, but the lung was full of lesions. So they told she can go back home. But they did not have any oxygen cylinder at home. The moment they tried to remove the oxygen, she becomes so breathless. So the husband was literally lost because the doctor told to take the patient home, but the patient needs oxygen, which they don't have. So they actually approached us asking whether we can give oxygen. This is another scenario where a young male, he was just 31. He was working in Gulf for many years. He had a very small kid. I think it was 2 3 years old kid and his wife. They both of them were from Tamil Nadu. They came to Trivandrum for getting treatment. Suddenly, he started developing breathlessness when he was in Dubai. He was some construction worker or something there. Then it became very bad, and they sent him back to his hometown. Then they diagnosed it as asbestosis. The whole lung was filled with particles, like he could not breathe. There was no lung space at all for the alveoli to expand and relax. So he was very breathless. Even with high volume, high flow oxygen, he was very breathless. He could not talk, he could not eat. He was always breathless, unable to lie, and he was referred to palliative care. So now we will come to what all we can do. So here you can see not just cancer, non-cancer patients will also have breathlessness. Especially you might have seen if someone dying, last few hours they will have respiratory symptoms. So breathlessness is not just for cancer patients. Any illness with breathlessness, any chronic illness with respiratory issues can come under palliative care. So, as I said, it is not just a physiological process, it is a language. They'll try to communicate with you through various breathing patterns. Many a times we will understand the mood of the patient, the psychological issues of the patient if you are giving clear attention to the way they breathe. And for all of us sitting here, we breathe involuntarily, right? We don't even know when we are breathing. We keep breathing and we don't even realize that how many breaths per minute we are taking. But the moment if something happens to the airway, it becomes very, very strenuous problem to think. You can't think of anything else, just the breath, right? If anyone here has gone through COVID, breathlessness during COVID, or anyone asthmatic know that if something small happens, then the breath becomes a very, very labored work for all of us. So there is a definition, not reading the definition, but I would like you to take that it is very, very subjective experience. As we said that pain is very, very subjective. My pain is different, your pain is different. Same way, breathlessness is also a very subjective experience. We cannot compare one person's breathlessness with the other person's. So how common it is? It can be, I can't say that that patient is breathless unless the patient have to tell that whether they are breathless or not. It is purely subjective. It is very, very commonly seen with lung cancers, and it is also seen in many other illness. I don't want you to read the entire thing, this you can take. It is also seen in any other advanced cancer, HIV, heart disease, COPD, and renal disease. So, breathlessness is not just for patients with lung cancer. It is also seen in many, many other illnesses also. And when the patient is towards the end of life care, when they are about to die, close to death, the breathlessness increases. Many of them, like 65%, patients will experience breathlessness at the time of death. So, patients describe two different patterns of breathlessness. We have heard about breakthrough pain, incident pain, continuous pain, etc., right, in the pain session. So, again, for breathlessness, patients describe in many ways. One, they say breakthrough pain. This is the most commonest type. That is, when I start to do something, when I get up to do something, I become breathless. Or if I start eating, or if I start talking, I become breathless. That is called breakthrough dyspnea. It can be continuous dyspnea, as in many illnesses. Like I said, interstitial lung disease. They remain to be breathless whole through the day and night. It is not episodic, it is continuous. So there are two types of breathlessness. And in non-cancer, you can see more dyspnea most of the time. They'll be breathless for a longer period of time. But in cancer, usually the breathlessness happens in the last few days of life, not continuously. What are the qualities of dyspnea? We have heard patients talking about qualities of pain, right? Pricking pain, piercing pain, throbbing pain. Same way, there are qualities for dyspnea. That means sometimes there are three different types of breathlessness. They can say air hunger, it can be work, or it can be chest tightness. I don't want you to learn the pathways as of now. If anyone is interested, you can read from the presentation. There are three types of breathlessness. One is air hunger. That means they know that I am unable to breathe. A simple example is when you go for a morning walk or a run or any exercise, you feel breathless. That means I need more air. I feel hungry for air. We understand that. So that we perceive that. There is an urge to breathe more. I cannot get enough air or my breaths don't satisfy me. that is called air hunger. It is usually seen in hypoxia. For example, in COVID, we might have seen hypoxia. Or during exercise, we will see air hunger. That is, I need more air to breathe. I feel hungry for air. The second thing is work or effort. That is, I have to take a lot of effort to breathe. What happens is that a simple example would be a patient with lung cancer will find it very difficult to breathe while eating. I need more exertion from my side to go to bathroom, to go to the toilet. They have to work really hard so that they can breathe. That is called work. And the third one is chest tightness. We might have all felt during COVID. There is chest tightness because of bronchoconstriction. That happens in asthma or COPD when there be that chest is tightened with something. So these are the three types of breathlessness. One is air hunger, second is work or effort, and the third is chest tightness. So what is the pathophysiology? I'm not talking about nerves reaching the respiratory center and back. This is the pathophysiology that we need to remember. What happens when someone is breathless? I'll ask someone of you. I'm sure many of you might have felt breathlessness. At least while walking, you might have felt panting. What will you feel when you're breathless? Anyone? What is the first thought, especially if someone had COVID? What do you feel when you're breathless? I'll wait for some response, either in the chat or you can unmute it.
Dryness of upper respiratory system and as well headache sometimes.
Yes. Anything emotionally, mentally, do you think?
As if they are going to fall or they are going to die.
Yes. Thank you, Mehboob. Anyone else? Fear of death. There is one from the chat. There can be fear of death. Anything else? Just curious to know what do you feel when you're breathless. Yes, we'll be very scared whether we are going to get a heart attack. Choking of neck, yes. Anxious, very true. So all of you have given wonderful answers. Yes, that is exactly the pathophysiology of this field. When someone is breathless, the first thing in palliative care, especially when they have having advanced illness, the first thing is that, as many of you mentioned, they become anxious and then they think, I'm going to die. And am I going to die without having air or without having oxygen, proper oxygen? What happens when you're scared? You breathe more, right? When we are going for some exam or some interview, when you are anxious, your breathing pattern changes. So when we are anxious, we breathe very abnormally. So that leads to feeling of more breathless. Then again anxiety, oh my God, am I going to die? Because my breath is very different. So it becomes a cycle where there is breathlessness, there is increased anxiety, fear of dying, which leads to more breathlessness. Is it clear? It is the very well known model these days where there is a connection between anxiety, fear, the work, and the breathlessness. We'll come to it again the end. It is called chronic breathlessness syndrome. It is called breathing, thinking, and functioning model. What happens when there is problem in breathing? We said when someone is anxious, there is a problem in thinking. There will be thoughts about dying, misconceptions, or in the past, they might have had some breathlessness. They will be very scared. Am I going to die? Which will cause more breathlessness. Once they are more breathless, what happens? They cannot move. They won't move. They just lie down or they just sit up. When there is reduced activity, what happens? There is deconditioning of limb, chest wall, and accessory muscles. When you don't use the muscles, it becomes weak. So when you are anxious, you have breathlessness. Because of that, you won't move. So your muscles are not active. Muscles are deconditioned. Muscles become weak. As a result, what happens? You will have more breathlessness because the muscles are not working. You need more effort. There will be increased respiratory rate. There will be use of accessory muscles, and you need increased work for breathing. Is that clear? It is called breathing, thinking, and functioning model. Everything affects everything else. Unless you reduce the panic attack, you can't breathe. Unless you start working your muscles, you can't breathe. Unless you breathe, your anxiety will not come down. So everything is interrelated. And what are the causes for breathlessness? It can be due to a tumor, a primary or metastatic cancer, or it can be due to lymph infiltration by the tumor. It need not be direct tumor, it can be lymphatic infiltration by the tumor. It can be due to pleural effusion. When someone is breathless, when you examine, if there is a dullness, if there is a pleural effusion, the moment you drain the fluid, the patient becomes so relieved. You don't need any other medication. So it can be due to pleural effusion. It can be due to some obstruction in the tracheobronchial tree. When there is a tumor obstructing the whole pathway, that can be one reason. Sometimes it can be due to some surgery, stricture, or some radiation or chemotherapeutic agents. And it is about cancer. What happens in non-cancer? It can be due to cardiac failure. You might have seen patients with end-stage cardiac failure, end-stage renal disease having lot of fluid overload. So they cannot breathe because there are a lot of fluid in the lungs and around the cavities, which the heart cannot pump. Then they start feeling breathlessness. And many other infections or COPD or pleural effusion, pulmonary embolism, all these can cause breathlessness. What are the causes? It pain. I don't know how many of you have noticed that when someone has severe pain, they breathe very differently. So we had a patient who came for pain management. So we were giving opioid IV morphine titration. So we were giving 1.5 milligram every 10 minutes. After some time, the pain has not come down. The patient told, I still have severe pain. But the titration was stopped. So then I asked why we stopped the titration. Because the respiratory rate is very, very low. So they thought the patient is going to respiratory depression. We know that we don't want that, right? And where there is IV titration, the moment patient becomes drowsy, we have to stop. The respiratory rate is very low, but the patient is in severe pain, very alert and conscious, not disoriented. So I was confused because the patient should become drowsy first before having respiratory depression, ideally. So I went and asked the patient why you are having, what is happening. I asked where is the pain, what are the radiation signs and everything. Then she told she has an abdominal pain. The moment whenever she breathes, there is pain. So she's controlling her breath. She's not breathing. She's just keeping the chest muscles tight so that she's not breathing. And that result only if she's very breathless, she takes one breath and stops. So the respiratory rate came down dramatically. So what happened? The pain caused breathlessness. And it is very common that whenever we see patients with severe pain, they have breathlessness. And as I said earlier, anxiety, when you are anxious, any of us, not just palliative care patients, any of us, if we are anxious, we breathe very differently. We become breathless. Anemia, that we all know, whenever there is low HP, we'll have breathlessness and some of the metabolic disturbances. And as I said, it is when we assess, it should not be just about breathlessness, it should be multifactorial. It can be due to pain, it can be due to anxiety, it can be due to anything. So we have to ask multifactorial things to understand more about the breathlessness. And of course, we should cater to the emotional needs of the patient. I have asked many patients when they are breathless, like, what is it that they think? They think that I'm going to die now without getting oxygen. So I'm going to die breathless. So that is what they are very, very scared of. Many of them have explained that in many different languages, that I'm being drowned. I feel that I'm in a chamber where there is no oxygen. So all these things patients explain to you. So we have learned about how to assess pain, right? So now it is about assessing or taking history about breathlessness. It should include the quality of dyspnea. What do you feel? Is it chest tightness? Is it air hunger? Or is it work or effort? And whether it is episodic or constant. And you can ask 0 to 10 scale, how intense is your breathlessness? Usually they will score. So it's very easy. Like in pain, you can ask 0 is comfortable breath, 10 is the worst breathing time. How is your breathlessness? And ask how has it impacted a patient's life. That means they are unable to move. Most of the patients, while breathless, they just don't move. They cannot eat or talk because of breathlessness. So understand how this has impacted their life. These are some of the scales, or which is one of the most important scale that you can use for assessing breathlessness. That is called Modified Medical Research Council. Usually we call it an MMRC dyspnea scale. It is a very commonly used dyspnea scale. See, it is very easy to assess. It is very good also to use. 0 is they are not troubled by breathlessness except on exercise, like we all have. We are okay to breathe, but once we exercise, we have breathlessness. Second is why when walking, like very speed walking or walking us uphill, we'll feel breathless. Third is we'll walk slower than people of the same age, even in a level road. Or sometimes we have to stop to take breath. The third one is stops for breath after walking even 100 meters, or every time you have to stop and breathe. The fourth is too breathless to leave the house or even dressing and undressing. We see in palliative care that very, very commonly that people say that I cannot move, I cannot talk, I cannot change my clothes because of breathlessness. So you can grade these breathlessness in MMRC. This is another scale. If this is mainly used for research purposes, it is called Modified Wald Dyspnea Scale. It is very good to understand this if you are in a teaching institution, or else you can stick on to the MMRC dyspnea scale. What are the physical signs? When we examine the patient as nurses, what will you look at? The first thing is how the patient is positioned. How the breathless patient usually, what will be the position? What is it that commonly seen by you?
Upright position.
Yes, upright position.
Propped up.
Propped up position, yes. Anything else? Those are very correct answers. And sometimes we call it the tripod position. They keep their hands like this, right? They keep their hands like this as a tripod and lean towards a table. Have you seen that? Usually in a home setting or sometimes in hospital, the table that you give for giving food, they keep their hands like this and rest their chin or something on that. So that is a tripod position. That is also very commonly seen. Semi-Fowler, Fowler, yes. Thank you, everyone. And check for the accessory muscles, whether there is nasal flaring, whether they are using accessory muscles. Check for respiratory rate and gentle percussion and auscultation. Does anyone of you do this auscultation and percussion in your daily practice as nurses? Is it involved in your daily routine examination of patients? Yes. So if you are not doing, try doing it now. Auscultate each other's chest. Understand how a normal chest feels. Once you get used to the normal chest sounds, then when you examine the patient, it is very, very important. Especially in palliative care, most of the setting, it is a nurse-led palliative care. The doctors will not be there with you to check whether there is any rhonchi or wheeze or anything. You have to learn on your own. So it is very important if you are not doing. Divakar, I saw yes. But if you are not doing others, start auscultating. Whenever you go to patients to take vitals, just listen to the chest for some time. Once you get to know about the normal chest sounds, then you understand about it. Is very good to learn. It is very good skill. Even at your home, if someone is breathless, you can check and see, right? It is very good skill to learn. I know you all learned this in the nursing school, but then maybe later on, when there are doctors, you don't need to examine this, but it is a very good learning. And any investigation, if our line of treatment is going to change, we can ask for some investigations if needed. So I'm just comparing the description of breathlessness and when the patient, how we connect that to the pathology. Severity, how will we assess severity? We can use a numerical rating scale. You can ask 0 to 10 scale. What are the precipitating factors? We need to ask when is it increasing? So usually they will say whenever I move, or when I go to toilet, or when I go to or when I remove my oxygen, then or when I cry or laugh too much, sometimes there will be more breathlessness, and there can be dyspnea due to emotional issues like anxiety. And ask for trajectory, whether it is continuous or episodic. Ask for past medical history, whether there is COPD or asthma or anything in the past, whether there is any occupational exposure. Ask whether they are taking any medications like beta blockers, which can cause a little breathlessness, or even NSAIDs at times can cause breathlessness. Then ask for associated symptoms like pain. Sometimes there can be vomiting when they are too breathless. Ask whether there is any blood in sputum or any severe chest wall pain. Everything you have to ask. So what is the management? First thing is understand the wishes of patient. Suppose I think that this patient has something. How will I send this severe breathless patient to a laboratory to get some investigations done? So whenever we think about investigation, we need to think how this patient can reach there, how we can do it in our setting. So understand the wishes of the patient and what are the likely benefits of treatment and what is the life expectancy. So every treatment depends on how long you think the patient is going to die or live. How long this patient is going to be there. If the patient is in advanced stage, if the patient is dying, then I may not send the patient to take a chest X-ray when the patient is on end of life care. So we need to understand the life expectancy of patient before we choose the treatment. And the decision making should be done with both the patient and the family. Usually the family will have their own opinion when they bring the patient to us. So this is one interesting study done in UK in medical school, Hull York Medical School. They have done a lot of work in breathlessness. So they have asked patients to explain how they feel or take pictures. So they try to create pictures from patients. They have some interesting pictures. I've taken only 2. So many patients felt that, see, her face is inside the cloud. So they are feeling otherwise good, but they can't breathe because their whole head is inside the cloud. There are a few pictures like someone sitting inside a big bunch of roses, because roses are really good, but they're covered with roses and the thorns, so they feel very, very painful and breathless. And they have told in this picture like what will help in reducing breathlessness and what will not help. What is one thing is coping. How you cope, engaged coping. Like you are aware that you are breathless and you try to cope with that. Second thing is help seeking. Sometimes people don't seek help when they are breathless. It is considered like sometimes they won't feel it is a maybe embarrassed to ask for help when they are breathless. And when you focus only on the disease, and the clinician is focusing only on the disease, that may not help the patient. So this is very interesting study. Once you get into their website, you can see a lot of pictures where patients have explained their breathlessness. And this is another very surprising study. So what happened is that patient reporting and the doctor recognition. That means out of many patients, the doctor thought, okay, these patients are breathless or not breathless, but it was the other way around. So there were 33 patients where the dyspnea was there, but doctor could not find it. Did you understand? Of 33 patients, the doctor did not pick up dyspnea, but 33 patients were dyspneic. And there was one patient who did not have dyspnea. The doctor thought he's dyspneic. So it is very, very subjective. We cannot understand when the patient is sitting in front of you. You cannot differentiate until and unless you ask them. And it did not, the level of intensity is not equivalent to the disease progression. So, as in pain, it is very, very subjective. In pain, also, we say, no, when someone is having chronic pain, if they are not screaming, then we may not believe the patient. We think that the patient is pretending because they are not crying. That is the same thing with breathlessness. Until and unless they start panicking in front of you, we may not believe. Sometimes they say, I am breathless, but looks very okay. So, believe the patient and ask more questions to explore. What are the correctable factors? So, now we know that the patient is breathless. Now we have to think whether there is an infection, whether there is an old history of asthma or COPD. Check whether there is any effusion or congestive cardiac failure. Check for the history. And check whether there is any chemotherapy, radiotherapy, or surgery they might have undergone. And coming to the management part. The very important part of breathlessness management is non-pharmacological approach. It is not medicines that comes first. It is always non-pharmacological approach comes first. So I've written walking aid, breathing training. So you need to ask your physio how to train them in proper breathing technique. I can't remember the name of the apparatus, the spirometer, where there is 3 balls. We always tell the patient to blow and give exercise. No, that cannot be given for all the patient. That is not the solution. So you have to ask your physio appropriate breathing exercise for each patient. How does walking aid help in breathlessness? Anyone can tell me? Can someone just tell me how can a walking aid help in breathlessness? The patient is able to walk.
The muscular activity increases the oxygen consumption.
Exactly. So we need to spare as much muscles as possible. We cannot use all the muscles all the time. Sometimes when we give walking aid to a breathless patient, they won't accept it. I can walk. I don't have any problem in my legs. I'm not bedbound. My problem is somewhere else. So we have to explain that you have to conserve your energy, right? You have to conserve your energy for breathing. It makes a lot of change. Once they are going to the bathroom with the walking aid, they can breathe nicely. But if they try to go on their own, they'll be very, very breathless. Even when they are sitting up, give a proper back support. Their effort is reduced. So they can breathe easily. If they are sitting unsupported, they need more effort to sit up. Then how can they breathe? So pacing the activities also is very, very important. When they change the clothes, when they take bath, simple things, keep the bucket over a stool so that and sit over there. Don't stand. And taking the cup of water will be very, very difficult. Then you can use the hand shower. It takes less effort. These are simple things, but for a breathless patient, even one single alveoli expansion is very, very crucial. Every muscle is important. And when they are eating, not like they can't eat something like a roti, right? They have to chew a lot. Swallowing is difficult. So should be something which is easily swallowable, not with much of a chewing. So these are the simple things to conserve as much as energy as possible. And some passive exercises. So I don't know how whether you are aware of the pulmonary rehab. Many of you might have seen pulmonary rehab. So they strengthen all the muscles. They give exercise for the hands, for the lower limbs, not just for the chest. It's not just about breathing exercise. They move every limb. Even in sitting, lying down, they tell to lift the legs or the hands, whatever is possible. So every muscle strengthening or preserving and this thing is very, very important. And I have written fan. There are a lot of studies telling that fan is a very, very effective tool for management of breathlessness. It's not the ceiling fan, but a handheld fan. A handheld small fan, when you're using it against your face, they say there is signals being transmitted to the brain, and the exact mechanism is not explained. It can be due to gate control theory or something, but handheld fan on the side of your face is very, very helpful in, you remember in the olden days when there is no electricity, what we do? We take the magazine and blow it on the side of your face, right? So it comes from the old practice. So if there is no electricity, you can just use some blowing on the side of your face. They say breathlessness is markedly reduced. But what we do in an Indian setting, the moment someone is breathless, we close all the windows, we switch off the fan so that the patient can breathe, right? Even when the children are having cough or cold, we close all the windows and switch off the fan, right? So to our patients, we have to tell to place the bed near a window, open all the windows so that there's clear, good circulation, and if possible, handheld fan. Then we come to pharmacological management one by one. The first thing in pharmacological management, the moment someone is breathless, what is the first thing that we do? Connect an oxygen cylinder, right? Is oxygen an intervention? Or is it not? Anyone? What do you think about oxygen? Is it a pharmacological intervention or non-pharmacological? I mean, I have put it under pharmacological. What do you think? Its pharmacology only is one chapter. Very true. It is a pharmacological intervention. So it is effective only if there is hypoxia. Like in COVID, it was effective. Why? Because there was hypoxia. What happens in many of our patients when they are dying? When someone is dying, they have to be hypoxic. Can someone die in 100% oxygen saturation unless you are hit by a truck when you're walking? Otherwise, the oxygen saturation has to come down. There are certain illness like COVID where hypoxia is the reason for breathlessness, or COPD. Oxygen will be helpful. There will be air hunger. But when someone is non-hypoxic with the chronic advanced or life-limiting illness, the effectiveness of oxygen is not really, there is no evidence to support oxygen. So what we do in our setting is that we give something called oxygen trial. We tell the patient that we'll give oxygen 2 liters per minute for another 10 to 15 minutes. Because you know that the relatives will tell you, please give oxygen, my patient is breathless. They wheel into the hospital actually asking for oxygen the moment the patient starts breathing. So we give oxygen trial. We explain to them why that lady with lung metastasis, the lung is full of tumor mass. Even if you give oxygen, where will she actually use it? Will it reach the lung? Will it reach the alveoli? Will it have an exchange? No. You're just pumping oxygen. That's all. The lungs cannot work. If there is a massive pleural effusion, what happens? The lung cannot move because there is a fluid collection around the lungs. Even if you pump 100-liter oxygen, the lungs cannot move. So we have to explain this to the patient. We have to tell why it is not being useful, but sometimes they still insist. So we tell them that, okay, we will do an oxygen trial. If the patient is getting relief, we will continue. Otherwise, we'll stop. So they agree to that. Then we give oxygen trial and ask the patient. And there is a big study done for oxygen, and they found that there is no significant benefit seen with oxygen therapy compared to room air. And oxygen is a clear barrier for communication because you have a mask. The patients cannot talk. We will not understand what they are talking. And it is very, very bothersome. You have seen patients taking out the mask every now and then, right? In the wards or in the ICUs. They take it out and then we tie their hands so that they won't take it out. So if you have to give oxygen, give it through prongs. We are not going to give anyway 10 liters of oxygen at a time. It will be anyway low flow for the advanced illnesses. So give it through prongs so that they can at least stop. It is not scary. The second management, pharmacological management, is use of opioids. The morphine and other drugs are very, very useful in controlling or palliating the symptom of breathlessness. We have to understand, we have to titrate really carefully. You don't need higher doses. We have to start with a very, very low dose. It is a mainstay of drug therapy in palliative care for breathlessness. But if I give morphine, the saturation may not come up. If you check the saturation may not improve, but the patient will feel better. The patient can breathe, they start walking. So the lady which I explained in the beginning, who had a lung cancer from an unknown primary, there is a lung mets, she was admitted to our hospital with continuous oxygen. She could not move. She was on high flow oxygen. She was brought to our inpatient unit. She was started on with 2.5 milligram morphine, 6 therapy. Next day onwards, she slept nicely in the same night. She started going to toilet without the prongs. She was very scared. If I remove, I'll become breathless. So she was very scared in the beginning. So we had to give her confidence by staying there. Gradually, she could go home without oxygen. She died within few weeks. But those few weeks, she was completely without oxygen at home. So, opioids is one drug that you can use. You may not notice any change in saturation. If you are looking at the ABG or saturation, you will not find any benefit, but the patient will tell that I feel much relieved. Usually, we start with a very, very low dose, not the pain dose. 2.5 to 5 milligram, 6 hourly, we can start. And check whether they have any frailty or any renal insufficiency. So, oxygen is like any other drug. Not all dyspneic patients will benefit from oxygen, and we can use nasal cannula. How does opioids help? Opioids help in perception of dyspnea. When you are breathless, your brain sends you signal that, okay, you are breathless. Morphine acts at that level and it will reduce the perception of dyspnea. These are all very important. And it will not respond to hypercapnia. When there is increase in carbon dioxide in your body, you respond, you breathe more, right? You pant. During exercise, there is hypercapnia. So you breathe more. But when you're giving morphine, the body's response to hypercapnia is reduced. Even if there is hypercapnia, the patient will not panic and breathe more. It has a little bit of anxiolytic, reducing the anxiety effect centrally. I'm not going into detail. So, next line of drug is corticosteroids. So, corticosteroids, we know that it can reduce the peritumor edema, it can reduce many of the lymphatic secretions and everything. So, anywhere from 4 to 12 milligram once daily is always given for breathlessness. So, how does it act? If there is an obstruction, it will reduce the peritumor edema. So, there is a space for air to go in. If there is any collapse or any lymphangitis, carcinomatosis, steroids are always helpful. So first thing is morphine, second thing is steroids, and the third group of drugs are benzodiazepines. Benzodiazepines will relieve anxiety. We saw the cycle, breathing, thinking, functioning model. So we need to reduce the anxiety so that the patients are less breathless. So to reduce the anxiety, we can give drugs like midazolam or lorazepam. If the patient is admitted in your IP, you can always give subcut midazolam. It will reduce breathlessness and the panic attack. They'll be very, very panicky, especially when they are dying. So midazolam is one drug that can reduce the panic attack and thereby reducing the dyspnea. So this is a flow chart that you can summarize all this. First thing is to start with when someone is dying and breathless, don't go near with them with a fan and then, okay. You have to relieve the breathlessness first and then you talk about fan and windows and other things. So it depends on what exactly the condition of the patient. If the patient is not in a very advanced stage, we can always tell them relaxation techniques, walking aids, fan, etc. And continue the non-pharmacological interventions, but you can start with a low dose of morphine and SOS basis benzodiazepine. So all through the trajectory, you continue the non-pharmacological management and you add medicines along with non-pharmacological. And if needed, long-term oxygen therapy. Like in COPD, you may need oxygen therapy and ventilation for some patients. So to take away points are the breathlessness is common in chronic, malignant, and non-cancer. So breathlessness is not just for lung cancer. It is seen in non-lung cancer patients also. You have to take a thorough history and clinical examination and focus on non-drug therapies. Non-pharmacological management is the mainstay in treatment of breathlessness. I will not cough. I am just going to the end of life situations where, sorry to skip. This is another important thing, another important topic for nurses. That is noisy airway secretions in last days of death. Has anyone heard this noisy secretions when someone is dying? As someone not Strider? Anyone?
Especially old patients, we have seen.
Yeah. It happens with most of the patients when they are dying. It's called death rattle. It will be very loud. And you don't need a stethoscope to hear it. While standing near the patient, especially when there is a normal death. I don't know whether you are seeing patients mostly in a ventilator dying. If they are dying naturally, there will be a loud noise when they are dying. You don't need to auscultate. Even when you're standing near the patient, you can hear the loud noise. Sometimes people call it stridor. It's not stridor. It is called death rattle. And how does it occur? Anyone? Any guess? I'll wait for the response. Anyone? Any clue? Why there is a lot of noise when someone dying? Where is it coming from? Ma'am, you're muted.
The muscles gets relaxed.
Yes. So,
So that becomes an obstruction in the airway.
yes.
So
You're
that the
getting
voice comes.
Yes. Yeah, ineffective, very true. Ineffective airway clearance. Your muscles are becoming weak. So you naturally have saliva. Everyone thinks that it is infection and there is a lot of sputum. It is not that. You naturally have oral and oropharyngeal secretions which get pooled on the back of the throat because your muscles are not working, as Madam said, and Divakar has also mentioned in the chat that there is no clearance. It is not being cleared as the way it should be cleared. Everything gets pooled in the or back of the throat or in the oropharyngeal region. So what happens when you have a cup of juice and a straw and you blow through the straw? What happens? There is a noise, right? Bubbling noise when you blow into water with a straw. So whenever the patient breathes, the air goes through the spooled secretions. That will create a noise. That is what we hear as death rattle. And usually relatives will be panicking and telling you that please do something. He's breathless, lot of sputum, he's having infection. Let's admit him in a hospital, let's treat pneumonia. Even the doctors treat it as pneumonia. Right? It's very common. So it is the pooling of secretions, ineffective airway clearance, and the saliva and whatever secretions in the oropharyngeal region is getting pooled. It is usually seen in patients who are unconscious or semi-conscious who cannot expectorate, who cannot spit it out or swallow it. It is very commonly seen, at least half of the patients dying normally, they will have this death rattle. Generally, relatives panic very much when there is like death rattle. So this is something that you need to explain to them, that why this noise. We know it is ineffective airway clearance, but we have to tell the relatives that why this noise is coming. Make it very, very clear. What about suctioning? Anyway, there is pooling. Can we suction it out? Will it help the patient? The patient is dying. This is death rattle. Is it recommended to do suction, or what should we do? How should we manage this noise? It is not pleasant for the caregivers, right? When someone is dying and making lot of noise. And how will we understand whether the patient is in distress or not? Yeah, I can see we can ask family members. What will we ask, whether to suction or not? Family members are going to tell you that please do something. There is a lot of noise. They will panic like anything.
Keeping the head and sideways.
Yes. So positioning is very, very important. Because this is getting pulled on the back of the throat. The moment you change the position, most often this will start coming out very slowly and the noise will reduce. Usually, you may not need anything else. Any other comments about suctioning? You can suction out whatever is there in the anterior. You may not need. But once you are suctioning in the throat, what happens? You're poking something on the throat, which will stimulate more secretion. What happens when you touch your palate or throat with something? More and more secretions will come. You feel like gagging. Lot of secretions will come. So the moment you are putting a suction tube in, you are creating a stimulus to cause more and more secretion. So this will be an unending story. The moment you suck, more secretion will come. And for suctioning, you need to have something in your home, the suction apparatus. Usually people run around to get a suction apparatus when someone is dying. So you need to tell them why this is happening, demonstrate the positioning. Their problem is the sound, thinking that the patient is in distress. If the patient is in distress, you can see the facial expression. Usually there will be pain or other issues. Their face will be clenched, they will be clenching if there is some distress. Treat the pain and give a good positioning. We can use one drug if it is still there, if it is not getting resolved by positioning. The one thing is glycopyrrolate. This is usually used in anesthesia, pre-anesthetic medication. You can use 0.2 milligram or 200 microgram of medicine. It comes in an ampule. You can either give it sublingually or subcutaneously. If it is in a home setting, just open the ampule and pour the medication under the tongue. If the patient is in home. Or if the patient is, if the patient is admitted, we can give subcutaneous. You can go up to 800 microgram or 1.6, but you don't need to go that 1.2 milligram. You can go, but usually it subsides with 1 or 2 doses if you need. Even after positioning, what happens when you give glycopyrrolate? It dries up. That is why they use that in anesthesia, right? To dry up the tract so that they can put in the tubes or the patient won't aspirate. So glycopyrrolate will essentially reduce the secretion so that the noise will be gone. That's all. This is another respiratory symptom that we see, that is blood in sputum. Unless it is massive, if someone is having 500 ml of blood in 24 hours, that means that is a terminal stage. If it is a small hemoptysis, that may not be life-threatening. And what will you do? First of all, you need to ask whether to ask their primary treating physician, is there anything that can be done from their side? But if it is massive hemoptysis, then you cannot refer the patient to anywhere else. We can actually check if it is very small hemoptysis, check whether the patient is on some medication. Sometimes they will be on ibuprofen or diclofenac. That can be a reason for hemoptysis. If there is massive or moderate hemoptysis, we can give injection tranexamic acid. That's very common practice everywhere, right? Or estamicin. If it is a massive hemoptysis, we have to explain to the family that patient might be dying. I have seen only once the massive hemoptysis, but it was very traumatic because the patient is actually seeing the sputum in the tub, like lot and lot of blood coming out from the oral cavity. It is not like coming from a wound. If it is coming from a wound, you can just give some pressure. But if they are having massive hemoptysis, you just can't do anything because they are actually seeing. So we sedated that patient so that he's not, he told, I can't see, I'm getting scared seeing this. This is very, very disturbed. He was dying for sure because of the volume of the blood he was coughing out. So we gave him mild midazolam so that he is little less panicky and was sedated. Okay. The psychological impact from massive hemoptysis is very, very big because, as I said, we had the emergency box like dark colored towels, but when the patient is having hemoptysis, you can't stuff the towel anywhere. You can give it here rather than giving white cotton or gauze pads. You can just give it near the mouth so that the patient is not seeing the color. But this patient was literally coughing out into the tub. So it was a green tub, but still he knew that he was kind of dying. So we explained the family members about the situation. So I'll end my presentation there and I can take up a few questions if there are any.
So thank you, ma'am, for the excellent presentation. Anybody have any questions regarding this patient? Please ask. Anybody? I think no questions, ma'am. So I hope your presentation is clear to everyone.
I hope this understanding will reflect in your assignments because if you have understood everything, your assignment should come right. So if you have any doubts, please clear it now.
Yes, that's true. So before moving on to the case presentation, I would like to highlight few things. The respiratory symptoms. So, madam was taking a detailed session. What we do is we are nurses. We all are spending a lot more time with the patient. So we are the persons to identify most of the problems, and we need to be a good listener. We have to do the proper assessment. So if you do the proper assessment, definitely we can able to give a proper management to the patient and identify if the patient comes to you with the breathlessness, please try to identify the cause first. And also you have to be a good listener. Again, if you have an ABC, maybe an OPD department, at least go and talk to them and give the proper that position to the patient if a patient is become breathlessness. So and also you can take a proper history and give a take attention to the doctor's level also. They are the person to prescribe medications. So after the assessment, you have to, when you go for the management part, as ma'am said, there are two ways of management, non-pharmacological and pharmacological management. So always you have to look into the non-pharmacological management first, and then you can go for the pharmacological management. And also, she mentioned about the death rattle. So this is one of the very common symptom in end-of-life care patients. Usually the caregivers will become panic and they will be anxious about that. So you have the person to give proper education to the patient caregiver, and reassurance is also necessary, and also proper positioning. If your positioning is not supported, then you can positioning and all other moral care and is not beneficial to the patient, then you can move for the pharmacological management like glycopyrrolate or buscopan like that. So always you have to look for the non-pharmacological management first. And also, if you give a oxygen, as madam is already mentioned, always you can use nasal prongs. So and also what you can do is, if you give oxygen after 10 minutes, please go and check whether the oxygen support is beneficial or not. See, if the oxygen support is not beneficial to the patients, please report the physician and remove the oxygen. So if the oxygen is therapy is beneficial to the patient, then you can continue. Always you can use nasal prongs to the patient. So I think we can move on to the case presentation now. Sister Winnie will be presenting a patient story today. Sister Winnie, over to you. Sister Winnie?
Good afternoon, all. I am going to present 75-year-old man with cerebrovascular accident. Presenting complaints, he is disoriented in 2 days. He has the fatigue in 1 week, less oral intake in 1 week. He has restlessness. History of illness. George has undergone to the above knee amputation on right leg before 13 years. After the amputation, moving by the help of wheelchair. Now he can't move or sit on wheelchair after the occurrence of cerebrovascular accident. He have the pressure sore on the foot. Right now he is weak and not able to take food. Present there is a infected wound. Now he have dyspnea. He is suffering from restlessness and disoriented. Examination BP is 100 per 60 mm of Hg, pulse 68 beats per minute, SpO2 75%, respiratory rate 20 breath per minute. Wound is infected. Treatment and significant investigation, oxygen therapy, wound care, position changing, IV fluid therapy. Serum sodium level is 135 milliequivalent per liter. Serum potassium 3.1 milliequivalent per liter. Psychosocial aspects, he can speak properly. His wife is taking care of him and she is getting old. His daughter got married and son gone for priesthood. The above mentioned son is giving financial support for his treatment. Medications, tab aspirin, tab clopidogrel, tab glimepiride, tab telmisartan, tab amoxiclav 625 mg, tab Pandoc 40 mg. Main concern, pressure sore present, restlessness, physical problems, and fatigue. Summary, now patient condition is worse. Wound has to be healed little more. IV fluid therapy is going on, no oral intake. Discussion point. What kind of care should to provide to this patient? Can we improve the condition of patient? Is curative care possible to the patient? Thank you.
So thank you, Sister Winnie, for the presentation. Anybody need any more clarification regarding this patient story? Please ask. Otherwise, we can move on to the discussion points.
I have a question. Sister Vinny, the breathlessness started gradually or it was there from the beginning?
Restlessness was is gradually is started.
So, Sister Winnie, where is he right now? Is in the hospital or home?
He was in house. Then when his her condition is worse, he take to hospital.
Okay. Right now he is in home, right?
Right now he is no more now.
Sorry. So anyway, we will discuss these patients. Sometimes if we see these kind of patients in your settings. So same thing, we will discuss. Okay, so we will expect your answers first. You can put your comments first. What kind of care should be provided to this patient? If you have seen this kind of patients in your settings, how will you manage? Please put your answers in the chat box, or you can unmute yourself and talk. So we are waiting for your response. We would like to hear from you all.
I think we should start giving him some Ryle's tube feeding to improve his fatigue and general condition.
We advise them to put Ryle's tube, but his relatives is they can't see like this, and they are like this because we did not.
So what I understand was, they are insist to put a rice too, but they are not taking it. The relatives and the patient was reluctant to put a rice too.
Yes.
Right, sister? Yes.
Yes.
Okay. Then what will you do? Others, please. Others. We have around 35 participants. Please respond. So Divakar said we have give psychological support to the patient and family. And also he mentioned nutritional support and wound care. Okay. Naina mentioned about intravenous infusion. And also Tivagar again mentioned about the parenteral nutrition. Second, the early feeding. How will you feed? Sister Jaya. Any other opinions, comments?
If he is able to swallow, can give the.
Okay. So what about the condition, Sister Winnie? Is he able to? Is he was able to swallow?
Sometimes he can, but sometimes he cannot able to swallow.
He was not able to swallow properly. Dysphagia was there. So that is also not possible. So from these patients, yeah.
Treating only with IV fluid therapy.
Okay. So what was his last stage, that end of life care stage? Please, could you please explain a little bit more? Is he was comfortable or any problem?
In last stage,
Yes, yes, Sister Vinny. She's asking how was his death? Was it comfortable? How was the patient's last stage?
last stage he's with oxygen therapy, and he just before dying he was calm and quiet.
Okay, that's good. So he is a 75-year-old man. Okay. So lot of problems, psychosocial issues, and he was not able to swallow properly. Is mostly end of life care stage. If you have seen these kind of patients, what you can think about is if you are thinking about the nutritional support and all, your that treatment is beneficial. So what is the outcome of that? You have to think about that. So our aim is to improve the quality of life of the patient and their family. Okay, so the main aim of palliative care is that. But in end of life care situation, if you choose these kind of things, they like rise to insertion. That is very difficult. So after that, what is your outcome? What you are expecting? If you feed to a second hour early, is he was in normal stage? It's not. So you have to think about the prognosis and you have to talk to the patient family and unwanted treatments and the investigations please avoid in end of life care situation. If it is not good for the, always you have to think about the ethical dilemmas also. Autonomy, beneficials, non-beneficials. If you give something to the patients, is good or not, you have to think, do no harm. If you give intravenous infusion, again, if the patient is in an end of life care stage, definitely the fluid will increase the pulmonary edema and increase the secretions that can cause again a lot of problems. Okay, so that is also you have to think about that. So here, I think you have to give a symptomatic management to the patient, like wound management. If the patient is having pain, you have to treat for the same. And if he is able to swallow little bit, that is enough in end of life care situation. Okay, so no give go for a rights to feeding or intravenous feeding and all intravenous fluid insertion. If you give choose an intravenous line, sometimes you may not get a proper intravenous line. Then you will give multiple tricks. Again, painful situation. Now you will give pain to the patient, but out of that, what is the outcome? So that also you have to think about that in end of life care situation. If the patient is in end of life care, you have to be keep it in mind. So whether your treatment is beneficial to the patient or your treatment chosen is harm to the patients. These all things you have to keep it in mind. Madam, so
Yeah, I think you have covered enough. Like whatever symptoms, whether it is breathlessness or pain or vomiting, anything that you take, first thing is to understand the prognosis. Like we cannot say exact prognosis, but we'll be able to know where exactly in the disease trajectory the patient is in, like whether the patient is towards end of life care or whether he's going to survive. So depending on that, we have to choose. The treatment will be different for a patient who is going to live for years. But if we know that he's imminently deteriorating, any treatment, any nursing intervention that you give will be different. So this patient, Sister Vinny said that patient passed away. That means the patient might have been in a very late stages of his life. Whenever someone is, and I'm sure there is another session on end of life care, but when someone dies, things deteriorate. They stop eating, they stop talking, they stop drinking, and ultimately they stop breathing. So there is a gradual process in dying. We should be able to understand. We cannot expect them to have the perfect sodium, potassium, the calcium, oxygen, everything perfect, and then someone dies. It is not possible in this world. Many things will come down. So whether we need to understand what stage he is in. I'm sure Sister Vinny told the patient died peacefully, so he might have not had much of symptoms, and I'm glad that he could not have any issues while dying. But whenever we think of some intervention, including the tube, including the oxygen, including any injections or medications, we need to see whether the patient is there to take it, like whether the patient situation is right, appropriate to take all this medication. And someone has mentioned in the chat in detail that we have to, looks like the patient is in end of life care. So, but rather than putting the RT, we can talk to the patients and the family. And he was breathless. Today's topic was breathlessness, fatigue. The when someone is really cachexic, any cachexia can cause breathlessness. As we mentioned, the muscles are not working. So even if the patient doesn't have any asthma or cancer, see, this is a typical example. You see breathlessness in any illness. The patient had a stroke, became bedridden, became cachexic and weak. So then they developed breathlessness. And there was restlessness. We need to check whether there is a patient was constipated. Now the sodium and potassium looks okay. It can be due to stroke. The restlessness can be due to stroke. It can be due to something else. So these are the things which we need to look into detail, especially the breathlessness part, because the patient is weak, bedridden, and the muscles are not properly working. That is the, or fatigue. Any kind of fatigue, old age, frailty can also cause. It need not be lung cancer all the time. Whenever we think about breathlessness in palliative care, we think about lung cancer. No, it can happen in any illness, especially when the patient is dying. Most of the patients who die naturally will have change in breathing pattern in the end. So we should know how to understand what it is and to treat it. That's all from my side. And people have mentioned about the bed sore dressing. Even if the patient is dying, you should take care of the bed sores. I don't need to tell this to the nurses here, but even if someone is dying, we need to take care of the oral cavity as well as the bed sore and the whole body nursing care. That's all from my side.
So, I'd like to add one point. So, for the own care and end of life care, if the patient is having that really the end of life care, lot of slough. Sometimes it might have seen lot of that exudate and the slough necrotic tissue in the wound. So, that is not necessary. You do not remove the necrotic tissue in that end of life care that time. So what you can do is you can give a cleaning and dressing you can do the proper dressings, and also you have to ensure that the patient is not has any pain. If the patient is having pain, you can give some analgesics before dressing, but the intervention is not needed. You can do the cleaning and dressing. And also, madam was mentioned about the oral care. So that is also very, very important. If you are not giving proper oral care to the patients, again, it can cause a lot of problems. So oral care is also important.
Especially when you are telling that this patient was on oxygen. When you're giving oxygen to some any patient, the oral cavity becomes so dry. Oxygen is a very drying kind of gas. It can cause dryness and cracking of lips and tongue, and even the throat. You can see it will be very, very dry. So keeping that moist, especially when someone is on oxygen, is very, very important.
And also end of life care patients, most of them are breathe through mouth. So again, it can cause dry mouth. So oral care is very, very important. So any other questions? If you don't have any questions, you can wind up the session. Ma'am, can we wind up?
Yes, yes, we can.
Okay, thank you, ma'am, for the excellent presentation. Thank you, Sister Vinny, for the case presentation. Thank you all for your contributions. Thank you.